Okay, let's just jump right in. Welcome to this high-yield explainer built specifically for you, radiation oncology residents. We're going to distill decades of practice-changing GI trials into actionable, bite-sized knowledge, stuff you can use literally today in your clinic and absolutely need to know for your board exams. I know there is just a ton of data out there, but today we're cutting through the noise and focusing on the absolute essentials, the studies that truly move the needle.
So here's our roadmap. We're structuring this anatomically. We'll start down low in the pelvis with anal cancer, move up through the rectum, explore the upper GI tract, and finally wrap up with the biliary system. This is basically our map of the major paradigm shifts defining our modern standard of care.
All right, Chapter 1, Anal Cancer and the Triumph of Definitive Chemoradiation.
This is honestly a massive success story for our field. When you look at the EORTC, ACT-I, and RTOG 8704 trials together, the narrative is crystal clear. These trials cemented our bedrock regimen, delivering 45 to 50.4 Gray with concurrent 5-FU and mitomycin C is the undisputed standard of care. Why? Because adding that specific chemo combo to radiation drastically improves local control and, most importantly for the patient, it radically improves colostomy-free survival.
And the jump from RTOG 9811 to 0529 perfectly highlights our modern technical evolution. We finally moved away from those old, highly toxic 3D APP fields from 9811. Instead, 0529 brought us into the beautiful era of IMRT dose painting. We're talking simultaneous integrated boosts, 42 Gray to the elective nodes, 50.4 to the primary, and 54 Gray to involved nodes. And the payoff is huge, a massive drop in severe acute toxicities, which means fewer treatment breaks and a way better quality of life for the patient.
Now, grab a pen because here is a massive clinical pearl for your follow-up clinic. Thanks to a secondary analysis of the ACT-A2 trial, we know the golden rule: do not panic early. You're going to see patients at, say, 11 or 18 weeks who still have residual abnormalities. Do not immediately send them to the surgeon. These tumors are slow. They keep shrinking long after the radiation stops. The absolute optimal time to evaluate for a clinical complete response is 26 weeks. Seriously, memorize that number, 26 weeks.
Moving up the GI tract, let's talk rectal cancer and ask ourselves a really pivotal question. How did our specialty completely rewrite the playbook? How exactly did we go from basic preoperative radiation to the complex sequencing of total neoadjuvant therapy, or TNT?
Well, let's get into it. Section 2, Rectal Cancer and the TNT Revolution.
Tracing this historical evolution is absolutely crucial. It all kicked off way back with the 1997 Swedish trial, which proved the value of short-course radiation. Then, the landmark 2004 German trial came along and basically proved that preoperative chemoradiation is vastly superior to postoperative when it comes to local control and toxicity. And that brings us to 2021, where the Rapido and Prodigy 23 trials established the modern TNT paradigm, shifting all that heavy-hitting therapy up front, before the surgery. When you're comparing TNT regimens, whether for boards or just surviving tumor board, you need to know the two distinct flavors of TNT. Rapido used a short-course radiation approach followed by chemo, whereas Prodigy 23 went with induction chemo followed by standard long-course chemoradiation. But here is the kicker. Both of these approaches nearly doubled the pathologic complete response rates. We're talking right around 28% for both, completely blowing historical standards out of the water. Which leads us perfectly into Section 3, rectal cancer and the incredible shift toward organ preservation.
Because we're seeing such high complete response rates with TNT, we can actually start talking about organ preservation. And the OPRA trial numbers are super revealing here. If your goal is preserving that rectum, sequencing absolutely matters. Delivering your long-course chemoradiation before consolidation chemotherapy gives you a significantly higher 53% chance of preserving the rectum at 3 years. If you do the chemo first, that drops to 41%.
Taking that even a step further, the OPERA trial, with an E, looked at boosting the radiation dose to maximize that complete response. They showed that using a specialized contact X-ray brachytherapy boost skyrockets the 3-year organ preservation rate to an incredible 81%. But, and it's a big but, you've got to counsel your patients. This aggressive local boost comes with a real trade-off of increased late, mild rectal bleeding from telangiectasia.
Okay, for your boards and your day-to-day clinic, you have to know the definition of a clinical complete response colon. No guessing here. It requires a strict triad:
a digital rectal exam with absolutely no palpable mass, a direct endoscopy showing no ulceration or stenosis, and a pristine specialized pelvic MRI. Only when all three of these criteria are met, at least 8 weeks post-treatment, can you safely commit a patient to a watch-and-wait surveillance protocol.
All right, shifting gears and getting completely out of the pelvis, let's ask a pretty controversial question about the upper GI tract. For over a decade, the cross regimen has been our untouchable gold standard. But does it still reign supreme today? Let's find out in Section 4, Upper GI, where we're looking at some massive paradigm shifts in esophageal and gastric cancers.
This is a true heavyweight matchup that's actively changing national guidelines. In one corner, the legendary CROSS trial, neoadjuvant chemoradiation to 41.4 Gray with carbotaxol. In the other corner, the new kid on the block, the ESOPEC trial, utilizing intense perioperative FLOT chemotherapy alone, with zero radiation.
The survival outcomes here represent an absolute earthquake of a paradigm shift. For patients specifically with resectable adenocarcinoma of the esophagus and GE junction, the FLOT chemotherapy regimen nearly doubled the median overall survival, 66 months with FLOT versus 37 months with CROSS. That fundamentally challenges our long-held reliance on upfront radiation for this specific group of patients.
So, what's the big takeaway? Histology dictates your therapy in the upper GI tract. For adenocarcinoma, FLOT is now the preferred path. But wait, do not abandon radiation entirely. If you're dealing with squamous cell carcinoma, radiation via the CROSS regimen remains your definitive, undisputed weapon of choice.
And here's a quick clinical pearl to back that up. When treating squamous cell carcinomas, trials like NeoCrack 5010 out of China show just massive tumor downstaging. We're talking 84% of clinical stage 3 patients downstage to stage 1 or 2 with neoadjuvant CRT. It just proves radiation's vital, honestly irreplaceable role in treating squamous histology. Finally, we reach Section 5, Biliary Tract Interventions. Navigating the highly lethal, often data-sparse world of biliary tract cancers. As radiation oncologists, where do we actually fit in here? Consults on post-op biliary cases can be super confusing, but just anchor yourself to these guideposts. The BIL-CAP trial dictates 6 months of capecitabine as the standard adjuvant systemic therapy, but definitely keep chemoradiation in your back pocket for positive R1 margins thanks to the SWOG S0809 trial. And for advanced disease, the TOPAZ-1 trial made immunotherapy with durvalumab the new frontline standard. Now pay special attention to this magic number from a landmark retrospective study by Tao and colleagues. For patients with inoperable intrahepatic cholangiocarcinomas, if you can safely deliver a biologically effective dose, a BED, greater than 80.5 Gray, their overall survival and local control rates actually begin to rival those of patients who had surgical resection. It is a stunning testament to the power of high-dose ablative radiation.
All right, let's bring it all home and synthesize everything into some rapid-fire, high-yield clinic rules. For anal cancer, hold your nerve, wait 26 weeks to assess response. For rectal, embrace TNT and rigorous MRI protocols for watch and wait. For upper GI, histology is everything, FLOT for adeno, CROSS for squamous. And for biliary, when they can't operate, push that radiation dose safely above the 80.5 Gray bed threshold.
I'll leave you with this provocative thought as you head back to the clinic or hit the books for boards. As systemic therapies and immunotherapies grow stronger and stronger every single year, our field is shifting. How will you, the next generation of radiation oncologists, innovate and redefine the precision role of radiation in the future of GI oncology? Thanks so much for joining me on this explainer, and I'll catch you in the clinic.